break the confidence and let them survive, or hopefully get them help, that's the decision. That's what you do. Because they're influenced probably by depression or something that's making them not think rationally. So don't swear to secrecy for it all. Now, there are different scenarios, okay? And so it's a little hard to tell folks what to do, but I'm going to give you sort of 3 common scenarios that I've seen. Each case is unique, so you kind of have to think through it a little bit yourself. But let's say you're sitting with a friend or a family member, and they say, I'm really, really depressed. I just don't care if I live anymore. At that point, of course, support them and do the things I just mentioned. But at that point, you need to have a really hard discussion about them getting in to see somebody professional, and sooner rather than later, because that's sort of the first step. I don't care if I live or not. Do you see the difference, by the way? I don't care if I live or not is not the same as I'm going to kill myself tomorrow, right? I don't care if I live or not means, if God takes me overnight, I wouldn't care, but I'm not necessarily actively suicidal. Does that make sense? So in that case, there's probably time, a week or 2 weeks or something, to get that person in to see a therapist, to see a psychiatrist, psychologist, to get help, okay? So you have a discussion with them about doing that, and you try to get them in to see someone. Now, let's say 2 weeks goes by, and like it is in the real world, unfortunately. Let's say now it takes a month to get in. So 2 weeks go by, and the person then starts to say, I really, I told you I was depressed. I didn't care if I lived anymore. More I've been thinking about it. I think everybody else would be better off without me. And I went and I bought a gun the other day, and I'm thinking about killing myself. The gun's not right in front of them. It's not like you're worried they're going to just draw the gun and do it right that minute. But that's fairly much of an emergency, okay? You don't have to call 911, but if you can convince them to go to the hospital with you, you need to get them to an emergency room. Now, if they won't go, then you have to decide. But I would probably err on the side of caution and get somebody out to intervene. But if they'll go with you, then you take them to the emergency room, and hopefully, you explain the situation, and they get seen by somebody pretty quickly, and either get an appointment that day or the next day or sometime really close to get started on some treatment for the depression or whatever it is. Get diagnosed with what could be causing that. Now let's go one step further. So let's say now the person says all those things, but you get them in and they start medicine, and a week goes by, and as you know, it takes a while for antidepressants to work anyway, so a week's not enough time. But the week goes by, and the person, you walk in home from work, and there sits your spouse, or whoever it is, sits your spouse, writing a note. There's a gun, a handgun, and a box of bullets right next to it. And she says, or he says, you remember I told you I was thinking about killing myself? I bought a gun the other day, and, I'm writing a note to you here, but I might as well tell you these things now. I really don't care. I'm going to kill myself. Without putting yourself in danger, get the gun away if you can. If they're standing with it to their head, you got to call the police. And I think you need to call the police in that situation anyway, because that's definitely an emergency situation. You've just walked in on someone who's about ready to kill themselves. So that's an emergency. You call 911, and the police come out and they take them to the hospital. I told you that I would talk next time a little bit about what happens once they get to the hospital. I think that's what we'll do, is I'll kind of guide you through a little bit about what does the psychiatrist do in some of these situations, in the emergency room, in the hospital. What is the job of a psychiatrist? I think there's a lot of stigma about that. I think people think of psychiatrists as soon as I go to the psychiatrist, it's going to take all my decision-making powers away and stick me in a state hospital, and I'll never see the light of day again. Well, not likely. But that's what people think. So next time I'll talk a little bit about what happens. But suffice to say, they usually get in the hospital. In the U.S. and in Indiana for sure, because this is my experiences in Indiana, if somebody is suicidal and has a plan, they typically get in the hospital. That's the criteria for getting hospitalized, because that person's at high risk for hurting themselves if you don't. Now, what do we do what do we do about suicidality? How do we treat, what do we begin to do? So I'm not going to tell you all about like committing someone or holding them against their will or any of that stuff tonight, but let's just assume for an example case that the person comes in to see the psychiatrist. Okay, the first thing that happens is the psychiatrist has to take a very good history and try to figure out what's going on with the person. Are they depressed? Do they have bipolar disorder? Because until they figure out what kind of disorder is causing the suicidality, they won't know how to treat it, how to begin treating it. As you'll see in a minute, there's some things you can do that if you don't have the right diagnosis could actually hurt the person, make the person worse. So you got to know what you're dealing with first. Second thing is psychotherapy. In all cases, if someone's suicidal, you need to have them in psychotherapy. Now, what happens sometimes is they may be so depressed that they can't focus on the psychotherapy. I don't care. Get them in there, get them started, try to get some rapport going with the therapist at the same time that you get some medicine or some other treatment going, okay? It's much better to be on the medicine and the psychotherapy because, in my opinion, the more angles that you attack a problem from, the more likely you are to fix that problem or to have a better chance of getting that problem resolved. If you just try one thing and not the other, it's not great. It's like having diabetes, and what's the best way to deal with diabetes? It's not just to eat whatever you want and take your insulin. That's not what you do. You watch what you eat, you take your insulin, you exercise, you do all the things you should do, and that's a person who lives a good, normal, healthy life with diabetes. No different with the brain. Okay, so the psychotherapy is going. Now you have to decide what kind of medicine to use. The psychiatrist does that, I guess, not you guys, but I'll tell you a little bit about what goes through the psychiatrist's mind, okay? First of all, are there any FDA-approved medicines for suicide? So he has to think to himself, is there something I can give this patient that's proven to help prevent suicide? The only medicine like that from the FDA that they've approved is for patients with schizophrenia, and it's a medicine that's excellent. It's excellent in how well it works. It's called clozaril or clozapine. Very good medicine as far as how well it works. It unfortunately has quite a few side effects and other things. So, and it's only been studied to prevent suicide in folks that have schizophrenia. So it wouldn't be something you would use in somebody with plain depression, okay, or bipolar disorder. You would try something else first. Now, what about bipolar disorder? There is some data, some pretty good data, looking at bipolar disorder and folks that take lithium, and they found that folks that take lithium have a lower risk of dying by suicide than those that don't. So lithium, it's not FDA approved now, but there is some good data behind that. With bipolar disorder, and I've talked about this in here before, but you wouldn't want to give somebody bipolar disorder. You remember what that is, right? That's where they have mood swings. They get real high in their mood, sort of like they're on speed. It's called mania. And then they get depressed, very, very low. And we've talked about depression before. Most folks know the symptoms of that. So they swing like that, okay? You don't want to give somebody like that an antidepressant alone. Because what will it do? It might, if they're down here and they're depressed, and you give them an antidepressant, the data shows that they would either go right into mania, or they might bounce around kind of into a mixed state where they have symptoms of both and then bounce up and down more often than they would have otherwise. So the antidepressant will probably make them worse if it's given by itself. If they're already on lithium or they're already on some other Depakote or something else, some other mood stabilizing medicine, then you can sometimes use an antidepressant. Although I think psychiatrists are now starting to lean towards using that later on, after some other stuff that has worked or has been tried. Now, what about antidepressants for plain depression? Here's where it gets. You think it'd be obvious, right? For a long time we've used antidepressants since the 50s. For plain depression. I'm talking about major depression, clinical depression. And most all of us in the field, myself included, feel that these medicines are absolutely necessary if somebody's suicidal. You either do that or you do ECT. And the only time I would do ECT right off the bat, that's electroconvulsive therapy, is if I didn't have time for the medicine to work. They were that sick and they were that